Welcome to our podcast, Making Clerkship Click, with your hosts, Tanmay, William, and Nick. If you're a medical student, this is a podcast just for you to get quick and easy primers on high-yield medicine topics that you're likely to come across when you go through your clerkship blocks. So let's dive right in. All right, we are back. Welcome to another episode of Making Clerkship Click. Woo, woo. Click.
Yes.
My name is Tanmay, and I'm joined by my co-hosts, the superstar clerks, prodigy medical students, Nick and William.
Thank you, sir.
You weren't being effusive enough. There weren't enough superlatives there, bro.
There weren't enough, right?
Yeah.
My vocabulary actually falls short of
I'll let it pass.
of your genius. It really does. But we are here to discuss a problem that you'll encounter on multiple rotations. Pediatrics rotation, emergency rotation, family rotation, and that is febrile seizures. Woo!
Right.
Very, very important topic. Very, very important topics. It's going to be a super fun, super exciting, super informative episode. But before we begin, just a quick disclaimer. We are medical students. We are not medical doctors. So this is not medical advice. The information we are presenting is based on lectures we've received, some research we've done independently, and just clinical experience. So it is just for education purposes for fellow clerks. It's not meant to be a guide for clinical practice or decision making. So don't try this at home for sure. All right. So now we're talking about febrile seizures today, but I guess the most important question for today is, guys, what is a febrile seizure?
Shockingly, the name febrile seizure is exactly what it sounds like.
No.
Yeah, I know. It's a seizure that's provoked by a fever, specifically when you have a temperature greater than 38 degrees Celsius. Sorry to any American listeners we have. These occur between the ages of approximately 6 months to 5 to 6 years, and generally they peak at around 18 months of age. Specifically, they're thought to happen because the developing nervous system of specific genetically predisposed individuals is actually more sensitive to fever, and this can then provoke seizures. So, William, with that in mind, how do we classify febrile seizures?
Now, some things in medicine have 8 billion different classifications, but thankfully this one is a little bit more simple. So when we talk about febrile seizures, we like classifying them into either what we call simple febrile seizures or complex febrile seizures. And the reason that we care is that this tells us about the child's chances of developing epilepsy in the future. So a child with a simple febrile seizure has a 1% chance of developing epilepsy in the future, not really significantly above the 0.5% chance of developing epilepsy in the general population. While the child with complex febrile seizures has a high risk of developing epilepsy slightly at 4 to 6%. To be classified as a simple febrile seizure, 3 criteria have to be met. The seizure has to last less than 15 minutes. It has to be generalized, so not just affecting certain parts of the body, and cannot recur more than once in 24 hours.
Amazing. So let me take a wild guess here. If that's a simple febrile seizure, would a complex febrile seizure basically be anything that breaks any of those rules?
Top marks.
Amazing.
You basically passed the rotation right now. There you go.
At this point, I should just be an attending. Like, I don't even know why I'm going
honestly.
So complex febrile seizure is basically anything that does not follow those rules, right? It either lasts longer than 15 minutes. It has focality in terms of its nature. It's affecting some body parts and not others, just kind of based on which area of the brain is involved. Or it recurs more than once in a 24-hour period. So overall, when I think about it, I just tend to remember the characteristics of a simple febrile seizure. And if it doesn't fit into that criteria, it's basically a complex febrile seizure at that point.
There you go. Now, there's one really important medical emergency that we want to point out here, and this is something called status epilepticus. And this is important to know because it changes your management drastically if a child has this. So a child is in status epilepticus if they've been seizing either continuously for longer than 5 minutes or intermittently for 5 minutes without any sort of return to their complete baseline. And this is extremely important to be able to recognize because the risk of brain injury actually increases after seizing for that long. So if you have a child who's seizing for longer than 5 minutes, you need to treat them as soon as possible with benzodiazepines in order to stop the seizure activity. And in the setting of a febrile seizure, we actually call this febrile status epilepticus.
Okay, so now that we've talked about our three main entities, so simple febrile seizure, complex febrile seizure, and our febrile status epilepticus, let's talk about an approach to febrile seizures. But to make things easier for you guys to remember, let's start with a case. So, on this podcast, we seem to be in the pediatric emergency room a lot.
Love it.
But let's say we're back there again, and you guys are called to see 2-year-old Betty. And from what you hear from the nurses, her parents report that she became fussy and irritable a day ago, crying most of the time, and then had a seizure while in the car today. So you bring your clipboard, you bring your stethoscope, and you head off to see her. So, Tanmay, you have your clipboard, you have your stethoscope. How do we approach a seizure?
All right. So before I start using this clipboard for anything, before I start asking questions,
Before you've even asked a single one.
the first thing I got to assess is ABCs and vitals. I feel like we keep harping on this concept through most episodes, but I feel like that's the most important concept, right? And guys, if you haven't checked out our episode on primary survey, where we break down ABCs within the context of trauma, but the same ABCs, it's kind of the same thing everywhere. Do go check it out. Super helpful, super important. Use that in every situation.
Very smooth plug. Very smooth plug, Tanmay.
Beautiful,
Amazing.
beautiful.
But amazing. So you do ABCs, you do vitals. That's basically the most important thing. So most of the time, the patient will be stable. They would have finished seizing by the time you see them, right? You might be seeing them in clinic. You might be seeing them on the wards later. You'd probably hear about the seizure as sort of like a history event. But it is still quite possible that when you do see them, they're actively seizing, they're unstable. And that's when you really want to call for help. It's important to ascertain how long they've been seizing for, because if they've been seizing continuously for a long period of time, particularly 5 minutes, or they've been intermittently seizing without return to baseline for 5 minutes, they are in status epilepticus, and that requires immediate treatment with benzos. Now, the type of benzodiazepine used depends on what kind of access you have. If you have IV access, then you can use lorazepam. If you're going for the rectal method, diazepam is an option. And then midazolam could also be used if you're doing intranasal or buccal administration.
And for those who don't know, Tanmay, what is this buccal administration? Can you tell us the layman?
I'm glad you asked. I'm glad you asked. So that buccal would just mean like inside your cheek.
Okay.
Basically. I see.
Right. The smart people in medicine would call it buccal.
There you go.
Others pronounce it a variety of ways. So we'll leave those guys unnamed.
There we go.
May or may not be me. Who knows? Who knows? May not be you. I don't know.
Yeah. So back to Betty. So we completed a good initial assessment on Betty, checking her ABCs and her vitals. We see that she's stable and she's not actively seizing in front of us. You do note that in terms of her temperature, she does have a fever, was at 39.0 degrees Celsius. So with that in mind, we know she's stable, she's not seizing in front of us. We're okay to proceed with our history. So William, when you're approaching a patient like Betty here, what do you want to know on history?
Yeah, so on history, again, you guys are listeners out there, you're better clerks than we are. And you're going to take a thorough history overall every single time. But there are 3 important things we have to establish, particularly with febrile seizures. So the first thing is a good description of the seizure. The second thing we have to do is find a source for the fever, some kind of infectious focus. The third thing we have to do is rule out red flags that could point us to other serious diagnoses. So the first point, description of the seizure. A good framework to use here is the before, during, after framework. So before the seizure, was the child febrile, or were there other triggers like head trauma? It's really important to ask whether the child was neurologically appropriate right up until before the event, because if they had like a decreased level of consciousness for a period of time beforehand, we might be concerned about other diagnoses. You want a good description of what happened during the episode itself. So what it looked like, so loss of consciousness, eyes rolling back, jerking and twitching of extremities, urinary incontinence, all those features are suggestive of a seizure. You want to ask whether it was generalized or focal, and you want to capture how long that seizure lasted. Then you want to discuss what happened after. Did the child have any of the post-ictal drowsiness usually seen with the seizure? Have they returned to full baseline? And if so, how long did that take? Did they seize again within 24 hours?
So now after you get a full description of the seizure, the second element you want to focus on is finding the source of the fever. So you want to get a description of the fever, including timing and the maximum temperature. as well as any symptoms which might give us a focus of infection, like a cough, runny nose, which might be suggestive of a viral URTI. If there's ear pulling, that might be suggestive of otitis media. Or if there's vomiting diarrhea, for example, that might be suggestive of gastroenteritis. So you really want to screen for all possible infectious symptoms at that point. It's important to note that sometimes parents of the patient may deny any fevers prior to the seizure, and no fever is actually documented until they present to the hospital. But in either case, you want to go through entire sort of infectious symptomatic history just to see if there's any potential sources you can identify through history.
So finally, like William said, the third thing we want to check for are red flag features, which might point us towards some of the more sinister diagnoses that can be immediately life-threatening and prompt specific investigations. So some of these red flags include different signs of central nervous system infections, like meningitis or encephalitis, and these can actually present with a fever and seizures, so mimicking these febrile seizures here. So some of these signs include lethargy, irritability, or as well as poor feeding in a baby. You might also see bulging fontanelles in a baby. You could see neck stiffness, potentially some photophobia, as well as you want to check for any focal neurologic symptoms. You want to check the child's vaccination status and specifically look if they've received their vaccinations against Haemophilus influenza or Streptococcus pneumoniae. You want to see if there's any sort of history of trauma in the child, as well as if there's any sort of history of developmental delay that's been documented.
Okay, so in our case, we go and ask all those things. We find out that Betty's parents noted a fever of 38.6 degrees Celsius in the morning. When they were driving somewhere, she abruptly went quiet in her car seat, and all of her arms and legs began twitching and jerking. Her eyes were open and rolled upward, but she wouldn't respond when her name was called. The event felt like it lasted forever, but Mom and Dad checked their phones before and after the event and noted it lasted no more than 2 minutes in total. There was no period of decreased LOC before the event, level of consciousness, sorry, my bad. And again, it was very, very abrupt. And Betty was drowsy afterwards for half an hour, but has since returned to her normal self, and there haven't been any further seizures. She's currently fussy, active, and feeding well. She doesn't shy away from lights. There was no history of trauma before or after the event, and Betty saw her pediatrician for a checkup just last week. All developmental milestones were normal, and Betty's up to date on her vaccinations. This is the first time something like this has ever happened.
All right. So, I mean, William, you're definitely a genius medical student. LOC, huh?
LOC. I
LOC.
had to throw it out there. Otherwise,
is that line of credit or is that
why am I paying the tuition money at this point if I can't throw terms out like LOC?
There we go. So LOC line of credit.
LOC line of
or
credit.
Or LOC level of consciousness.
Level of
consciousness. There we go. All right. Amazing. So we've talked about some important concepts here. Right now we know the breakdown of febrile seizures. We've talked about some important elements on history. So now, guys, if this was clinical skills 101 history, what follows next?
5. Boom.
Oh
5.
My goodness. Oh my god.
Always get the 5.
Oh my god.
5 followed by social history. There we go.
You should just be the clinical skills coordinator at this point. That was music to their ears.
Yeah, we'll see. We'll see.
Nick.
Oh my goodness.
Amazing. Nick. I'm glad you said physical exam.
Yeah.
That's exactly what we're looking at next.
As always.
So on physical exam, the first thing you're checking for is ABCs and vitals. There we go. Surprise.
Wow.
Please check out our episode on primary survey if you haven't already done so. We talk about ABCs. So if you haven't done the vitals already, please do that. Patient may or may not be febrile at this time, but that's okay. You always do your ABCs and you always do vitals. Again, your physical exam with febrile seizures is really divided into 2 foci, kind of your history, right? You do your neurologic assessment within the context of that seizure, and then you want to find the source of the fever. So one particular focus you should have here is that complete neurological exam. You need to rule out any persistent neurological deficits, but also rule out any signs of meningitis or encephalitis, because that could also present with fevers and seizures. You also want to look for any damage to the skull that would be suggestive of head trauma.
So another important focus you should have in terms of your physical exam is looking for some sort of cause of the child's fever. So you want to look in their ears and look at the tympanic membranes. You want to listen to their lungs. You want to see if they have any abnormalities on their abdominal exam, as well as consider a possible urinalysis. And here, treating the underlying cause of the febrile illness, if you can find it, is really important for actually reducing the risk of future febrile seizures in the child. So moving back to Betty, as we said, she is febrile on physical exam, but you see on her ABCs and vitals are stable. She appears fussy in front of you, but she is active and non-toxic, and you do note she has some clear rhinorrhea. On neurologic exam, she is moving all 4 of her extremities actively and equally, and there's no obvious focal deficits. You don't see any signs of neck stiffness, and she's not doesn't appear to have any photophobia, and you don't observe any evidence of cranial trauma or any other trauma to Betty. Otherwise, her exam is completely clear, but just before you're leaving the room, you think back to this podcast and you think, wait, he said I have to look in the ears. And so you take a look in the ears, and what do you see? That left tympanic membrane is bulging.
Oh my
Boom.
God. Oh
Boom.
my God.
QuickShip is clicking at this point.
This one's already clicked.
Oh my God.
Yeah, there you go.
All right. So from here, next question after your physical exam is, well, what do I want to do to work this up, right? So let's talk about investigations. Now, which investigations you need depends on your clinical picture. So if you have a child with a simple febrile seizure with a normal neurologic exam, no further investigations are necessary relating to the seizure itself. But Sanmei, what happens if we have a complex febrile seizure?
So for complex febrile seizures, it's a little different. You are going to want to order an EEG to look for possible underlying epilepsy. And you might consider ordering a head MRI to rule out structural pathology if you suspect that on your exam, or if the patient's seizure story suggests a possible focality. In this case, they will also definitely need a referral to pediatric neurology for further follow-up and management.
And finally, it's really, really important to mention again that whenever you're evaluating a child for febrile seizure, you have to be on the constant lookout for signs of meningitis, which is something really, really important on the differential. So if you see any of those signs that we talked about previously, so lethargy, irritability, bulging fontanelles, photophobia, neck stiffness, just order a lumbar puncture. You should also order a lumbar puncture on any child less than 12 months old with a febrile seizure, as the signs of meningitis can be too subtle to detect clinically.
So going back to our case, Betty seems to have had a simple febrile seizure based off the history, and this is likely provoked by an acute otitis media based off the physical exam findings. And there's no red flags present in the history that we've gotten from her parents. She appears well overall and is feeding appropriately. Because of this, with that simple febrile seizure, no further investigations are necessary at this time.
Fantastic.
So now, exactly. So shifting over to management now. So management for a patient with a febrile seizure, as many things in medicine, depends on the clinical picture in front of you. So for, like we said, for status epilepticus, where you have seizures either continuously or intermittently without any return to their baseline for at least 5 minutes, you're going to call for help and you're going to give them benzodiazepines as soon as possible.
Now, most children you see would have returned to baseline by the time you come and evaluate them, right? That's just like probability-wise, that's likely what you're going to see.
Yeah.
So for these kids, you're going to want to still treat the underlying infection. And that's just going to kind of depend on what sort of infection you screen for. We talked about the history and physical components, and you kind of treat accordingly. And then ultimately, you want to do some good parental counseling, because this can be quite a terrifying thing for parents to watch, right? Their kids seizing. And it's important to counsel them and educate them on what to expect going forward. And I guess the FIFE becomes very important here, right, Will?
Of course. You want to let parents know that febrile seizures happen in up to a third of children, and the vast majority of them do not last long enough to cause any form of brain damage. Most children with febrile seizures also don't go on to develop epilepsy. However, there are a couple things they should do if the febrile seizure happens again. The first thing to do is to place their child on their side in the recovery position in a safe place to prevent any form of aspiration. Don't try and hug them close or restrain them. Keep them away from dangerous objects so they don't hurt themselves, and don't put anything in their mouths or they could choke. It's also really important not to leave them unsupervised in the bath. If they have another febrile seizure in the bath, they could drown.
The second thing is you want to inform the parents that they need to time any future seizures. So seizures can feel like they last an eternity if you're watching them, but in reality, it's really important to actually get an objective measurement of how long they're lasting. If they are lasting longer than 5 minutes, you want to call 911 immediately, and depending on the situation, you can either discharge the patients on some sort of prescription for either buccal or rectal benzodiazepines, and the parents can actually use these to treat status epilepticus at home while they wait for the paramedics to arrive on the scene. Lastly, a really important thing here is it's actually been found that there's no prophylactic therapies that are actually effective for febrile seizures. So just giving Tylenol or Advil does not actually help reduce the risk of future febrile seizures, but they are important, as always, for treating symptoms related to, say, the cause of the fever in general, but they won't prevent further seizures.
So just going back to our case again, we inform Betty's parents of all those things. We prescribe her amoxicillin for her otitis media, and then we provide them with a prescription for buccal midazolam in case of future status epilepticus. And then Betty gets discharged home, and her parents are told to follow up with her family doctor or pediatrician just for continued management and follow-up.
Happily ever after. It's beautiful. It's a beautiful case.
There we go.
But boys, we talked about a lot of stuff. Today, it's time to sum up. So, febrile seizures are seizures in response to fever that occur in young kids. It's thought to reflect a vulnerability of the developing nervous system to fever in some genetically predisposed individuals. We split them into simple and complex seizures in order to assess the risk for epilepsy. We do this based on how long the seizure lasts, whether it was focal or generalized, and whether or not there's recurrence within 24 hours.
Simple seizures last less than 15 minutes. They're generalized, and they do not recur more than once in a 24-hour period. Complex seizures, on the other hand, break any one of those rules. We also have to watch out for status epilepticus, and that's basically one seizure or intermittent seizures without returning to baseline that last longer than 5 minutes, as this is a medical emergency and can cause brain damage if left untreated.
So shifting to your history and physical, it's really important, as always, to start with an assessment of the patient's ABCs and vitals. Next, you want to get an understanding of what happened before, during, and after the seizure, as William mentioned, and check for any red flags that could lead you to potential other sinister diagnoses that could be immediately life-threatening. In particular, you really want to watch out for signs of meningitis, trauma, as well as developmental delay in the child.
Yeah, it's important also to look for any focus of infection because you can treat that. And again, if you treat the fever, hopefully they don't have seizures going forward. In terms of investigations, simple febrile seizures usually don't require any investigation. If you have a complex febrile seizure, though, order an EEG and consider an MRI of the head if there's focal signs. Finally, and most importantly, if you're seeing signs of meningitis or the child is less than 12 months old, just get an LP. Meningitis can be lethal, and it's too important to miss.
In terms of management, finally, status epilepticus must be treated immediately with benzos to avoid brain injury, right? And ABCs, you definitely want to watch out for that. Most kids, though, when you see them, would have returned to baseline by the time you assess them, and then they simply require treatment for the underlying infection and just set them up with the appropriate follow-up.
Lastly, you want to counsel parents that febrile seizures will recur in up to 1/3 of children, and the majority of these seizures will not last long enough to cause any permanent brain damage. Most children with febrile seizures do not end up developing epilepsy. However, next time that their child has a febrile seizure, you want the parents to put them in the recovery position in a safe place, make sure they don't restrain them, and don't put anything in their mouths. You want them to start a timer as soon as the seizure starts if they can. If the seizure lasts longer than 5 minutes, you want them to call 911 and administer benzodiazepines as prescribed.
Perfect. So that brings us to the end of our episode, folks. And that's our breakdown of febrile seizures. I think that was a super, super informative episode, guys. Like, what do you guys think?
You know, does that make it any different than the rest of our episodes? You know, it's just one more episode in a long pattern.
You do speak the truth. And the most important takeaway from today's episode is LOC William. One more time. Well, what is it again?
You know, sometimes looking at my line of credit decreases my level of consciousness. So I think that's why I get them confused sometimes.
Amazing, guys. So bit of a longer episode, but super critical information. You're definitely going to use it on pediatrics 100%, likely on emergency medicine too, on family medicine as well. And hopefully this approach and this information really helps you out, right? Gives you a systematic approach to really tackling febrile seizures and thinking through presentation, investigations, and management. And hopefully this would make you a superstar clerk on the wards.
If you weren't already, there you go.
All right. Thanks for listening. See you guys next time.
Easy.
Peace.